There you go.
Hi, everyone. My name's Boomy with Wisconsin Health Literacy. We're going to go ahead and get started. Just a quick reminder for everyone to please fill out a survey for each session. Surveys can be found in the app, or you can scan the QR code that's behind your name tag. So today's speaker is Kim J. Kim has worked with Sinai Urban Health Institute since 2012 as a community health worker and trainer. Her role is to educate patients in some of the most underserved communities on their specific conditions, as well as deal with their social determinants of health. This role is achieved by applying health literacy and health equity. So welcome, Kim.
Hello, everyone. I am so glad to see so many people in this session this afternoon. I promise you, you will totally enjoy it because I feel passionate about the work that I do in community. So, welcome to the session. I am going to be flipping back and forth between glasses because when I'm at the computer, they don't agree with me. So, I will be flipping back and forth. So I know that there's a discrepancy between the titles in the book and in what's on the screen, but the content is still the same. It's about creating content that's equitable to onboard community members to effectively do their roles, especially in the area of contact tracing, which is the aspect I'm going for from today. So first of all, I have nothing to disclose. Nobody's paying me any money to do any of this work, to speak about this topic, so nothing to disclose. In the agenda, we're just going to talk about the background, developing the COVID-19 response core, how we incorporated health literacy in this process, and the evolution of the training program that happened. So just a little bit about me and my background. Who is Sinai Urban Health Institute? We're actually the research arm of the hospital that we sit in, which is located on the west side of Chicago. We've been doing community health work and this particular profile of work for over 20 years. So we've honed the best practice on what to do to effectively put a community health worker and a community member in this role with the proper education and support. So we have campuses on the north and south side of Chicago in the most underserved communities, which we do service, and we are considered a leader in the community health worker model. So what did we do for this COVID response approach? Now, we all know, you guys remember something called the pandemic? Absolutely. So at the start of the pandemic, there was a need, there was a necessity to put people, boots on the ground, to address what was happening in the community, what was happening in the world. Who is going to do this work? Because the manpower, we just don't have it. So what we had to do was do a different approach, and that was to really onboard and get community members ready to do some very critical work. And how do we do it? What happened? So this graph really shows the inequities that face the communities that we were focusing and targeting. So these rates show that in the Black and brown communities that were being serviced, that the amount of times that a Black person or a Latinx person was infected by COVID was 2 times their counterpart. And this is not news to most people who do work in underserved communities. It was really right spot on with what was going on and then what we needed to do to focus on how do we address the issue. So what happened was there was a program that was developed. And what happened, a bucket of money was attached to a satellite organization, and I'll talk about those partners. They were given the funding, then they trickled down the funding to invest in 31 community-based organizations. These 31 based community organizations were then charged with hiring a cohort of contact tracers who would later do the work that we were speaking about before. And it had to target those communities who were dealing with the most deficit in services and also hardest hit by economic development. So imagine you have this pandemic that's pounding the nation. Then that's compounded by folks who've lost their jobs, who are most of the essential workers. Then the loss of income. There was just a lot going on. So this partnership was really crucial in making sure that not only the work was being done, but it also employed a population who was hardest hit by the pandemic. So to speak to the partnership, these different organizations that were located in Chicago were research-based, which is my organization, Sinai Urban Health Institute. Also, University of Chicago School of Public Health, Malcolm X College, and also NORC. And these entities were charged with onboarding a cohort of over 600 community members to do work some of them have never done before in their life. So this map is just an illustration of the areas that were hardest hit and those that we needed to target. And again, these are the same people who were employed, who were experiencing the same effects of what was happening. But this map really is just an overshadow of what was already in existence. Those same disparities were hitting these communities, and these were the same people who were now charged with moving the needle to health equity. So a lot of the people who, again, were hired to do this work by the community-based organizations on this boots on the ground level, these were the same community members who, again, were dealing with food insecurity, were dealing with housing insecurities, and even their own personal insecurities about the pandemic and what it was. There were so many things we had to battle, considering what were the own inequities that people were fighting against to even get medical care. Because to them, in their eyes, COVID was the enemy, and not to mention a vaccination. Oh no, that was not gonna happen, not without a fight. And we had to address a lot of things that were a community-based discrepancy before we can even get to all the other things that were necessary to do the work. So what we really had to do, once we decided what the protocol was gonna be, we knew that there was a charge to address the hesitancy itself. So what did we do and how did we do it? So the community members that were hired, we really had to listen to the needs of the core members. They were the ones who were going to do the work. We had to really trust in them to get the message out about COVID, about how to quarantine, all these different components. But they were also dealing with their own hesitancies. And in order for somebody to effectively buy in, the person selling has to be a believer. Is that right? Okay, because like how can you talk about a good shoe and you don't wear good shoes? So we had to make sure we address the scenario. And what happened was a lot of the members who were selected had different roles. I already told you I work for the research arm of the hospital. Part of my role is training, and that training component is what we call CROWD, which is the Center for Research Outcomes and Workforce Development. Our team was charged with the second leg of the implementation of education and knowledge. They went through Malcolm X College to get the foundational training for COVID-19. They went through that training. It was a self-paced module, introduction into contact tracing, so they can really get this team of people up and running. They came to CROWD for what we call core skills training. And this was foundational training that is really modeled after many states to give training in health literacy, motivational interviewing, cultural competency, and even ACEs. But again, how do you onboard people with such a large amount of distance between knowing a lot and knowing barely anything? We had to get all these people together via Zoom. Who does that? And get a sense of community amongst them to get them to collaborate with one another, learn from one another, and learn alongside one another. And many of the organizations that were charged to do the work had never done anything medically at all. So to say some of the cards were stacked against us is like, whoa. how do we do this? And you had to look into the face of people that were really hurting themselves and tell them you can do this. And many days, many sessions, we had to cry with one another to get us to that point of understanding that the work we had to do was powerful, but how do we do it? How do you do that? So once the initial training was layered on through Malcolm X College, and they came to us to get that foundational training under the CHW model, they were still new to contact tracing. So we had to support them with questions that would come up about the role, about their own hesitancy on a regular basis. It never stopped. So what we stood up, what we called, were 3 components. We had our office hours that we would do every Friday, that within that time, they can talk about whatever they were experiencing in their role, get the support that they need, and then also identify areas that they needed more support in. So if they came to that Friday session and they said, you know what, guys, what you taught us about motivational interviewing is good, but I think we need some more help with that. And if that was the consensus of the group, that is the training we were able to give them based on what they needed, not to check a box. So the different areas that we had were what we call our office hours. Then there was the communities of practice. Office hours was just as it stated. It was an hour, a quick hour. What do you need? How can we help you? This is the fix to this. But communities of practice has a different approach. They still had that opportunity to sort of level set about what it was that they were going through in their role and what they needed to be supported in so that they can get the job done. And then we offered in that area of specialty needs that they would ask for. So whatever professional development that they needed, we gave it to them. If somebody came to that session saying, I don't even know how to turn on my camera for Zoom, which button do you click? We helped one another in that space. So no question was too small or too big because we knew there was work to be done and we had to do it together. So there was always input received from the collective. It was never about what we wanted, it was about what they wanted. So meeting people where they were was the essence of how we committed to this process, because we had to turn these hesitant community members into trusted messengers. We had to address every concern about what's in the vaccine. Am I going to be microchipped? Am I going to become a zombie when they turn on 5G? What about what they did to people of color in years past? How do we get past that, Kim? So how did we get past that? We had to bring in the big guns. We brought in the experts. We brought in the medical staff that looked like them, that could relate messages to them, that they get it. You heard earlier in the first plenary with Dr. Andrews about meeting people where they were. Even those who were very well educated had to be brought to a certain semblance of understanding to say, this is not accurate. We did a fact and truths and facts all during this session. Dr. Arwadi, she's a very well-known physician in Chicago who was also part of the Department of Public Health, who would come to these sessions. They would see her on television, and then she would meet us in those sessions to apply a health literacy approach to what was going on with those who had these doubts about what they were talking about. How can I tell you to get a vaccine if I don't believe in the vaccine? So all during this time, again, it's always input. Input, input, input. Because there's a saying in the community health worker world, nothing about us without us. So even when you're developing curriculum, you have some boxes that you think it falls into, but then you know what I'm going to do? I'm going to come over, I'm going to hand this information and say, Bummy, do you think this is appropriate? Is this community applicable? And if it's not, we have to start over. Because again, our job is to make sure that what we are sharing with our community is what the community feels to be accurate and appropriate. We had to go through the data collection tool that they had put up for contact tracing and make sure it was appropriate. We had to make sure that it was appropriate for Latinx community, for the African American community, and also for the LGBTQIA community, and all those in between. Because everybody had to feel like you were talking about them and you cared about them. So when you are creating any kind of process or protocol, it's important to include those who you are trying to reach. We utilize a popular education model, which means everybody comes to the table with a degree of knowledge. We all are learners and teachers in this space. So again, how do you create this sense of community and camaraderie in a virtual space? Nobody can touch, hug, really get that energy. So we had to develop a culture. We had to show up on camera. We had to show up appropriate on camera. We couldn't lay down and sit in the back and eat snacks while we were on camera at work. That's not how you do it. So we had to go through all those processes. But then they felt like they had support. There was somebody there who was listening and believed them when they said, I just don't feel comfortable. So then it was, what do we do to make you feel comfortable? And that process continued with every office hour, every community of practice. Input and implementation. Does that make sense to the room? Okay. So again, to talk more about those office hours, it provided a place of support. Many people would come there with their own challenges about what they were experiencing from the pandemic themselves, the losses, the fears of having COVID, and all you heard on the news about those who had COVID was what? What was the message? You're gonna die. So everybody, whoever, they never talked about the success stories of how do you get through it. It was always the end result. So everybody was operating out of fear. And again, if it's going to be culturally appropriate, and if it's going to apply a health literacy to it, we have to address all of those situations and issues. And it never stops. It's ongoing. So we had to change the narrative a bit to say, okay, what is the worst thing that can happen if you're not vaccinated? We had to hear those responses. And what's the best thing that can happen if you get vaccinated? And we heard those responses. And in those spaces of talking and sharing, people were able to connect because the situations they had been through were quite the same. And so when somebody had been through it and they mastered it, they shared that in those spaces, right? And as they shared those in those spaces, some other folks got inspired, right? And then they got motivated, and then they learned from one another. And that was the most helpful experience throughout this entire process. Now imagine taking over 800 people through this on a regular basis. We did it. It happened. But because it was tailored to those needs in a way that they got it, made the difference. So within the framework of the communities of practice, because office hours was one thing, but the communities of practice was where they got that additional training and professional development based off of what they asked for. So this would happen. In the beginning, we would do it every week. But as they got better and better at doing the work, it went down to just doing it every month. Right now, currently, we're bi-monthly because they're so surrounded with support and plain language and information that makes sense so they can share it, we don't have to meet as much. But it was essential when we first started out. So we made sure that as the spectrum changed of what was needed, we changed, we shifted. Because the curriculum could not remain the same and be applicable to the role at hand. 1 week, they were on hotlines telling people to quarantine, telling people to definitely understand what to do when you had COVID. They were applying services of other social care systems for food, for housing, for other issues that happened in the house with lights being turned off. They had to deal with that as well. But then the shift came. They had to go outside now and started dealing with people door to door. How did they do that? They never done it before. But again, if that was what was needed, that is what we provided training for and continued support to make sure that in order to do this role well, we had to apply applicable training to the audience at hand. So it means also health literacy and even health equity means that you have to give people what they need, not just what you think that they want. Does that make sense? So if you are somebody that I can tell you, yeah, go ahead and take your medication twice daily. It's important for you to maintain your medications so that you will feel better. You probably say, oh, I got that, Kim. Others, you might say, yeah, take your medicine twice a day. You need to take this so you can take care of your health. And they'll say, what do you mean twice a day? And so when our core asked that question, how do you address that? And then I said, okay, we have to get to the why. So we had to teach them how to get to the why in order to answer the question that they already had the answers to. But they had to give the response in the way that would make sense to you, or even you. So it was always a learning part of their job, always continued learning. So we know that in doing anything, there's a degree of stress that comes into place. You get discouraged because you're doing this role that's not only affecting your community, but it's affecting you. So those communities of practice became a safe space. They became a place where people could sort of download and even share when they were afraid. They could share when they were having issues with managing working from home and being in the house all day and get that support. In addition, they wanted to understand about that motivational interviewing. What do you do? How do I get people to open up and talk? How do I manage those things? And even the realms of community health work, what that meant. Because when they came in the door, some of them had no training whatsoever. Zero. And others had, some of them were degreed physician assistants actually, that were doing community health work. But when they came into this space, they even helped us deal with the health literacy component because they learned that the things that they learned in school had to be modified because it did not reach the population that they were serving. And that was so very important in making connections and delivering information to this community that was already so beaten up and battered by what they were going through historically and currently. So in doing this training, we found out a lot of things that people were excited about public health. And they had no idea that they were until they were exposed to things that made sense to them, and now this role made sense. So they would give us feedback on, I never thought I could do stuff like this. The training was good for me, and it allowed me to do this great work that I never thought I could do. And it wasn't boring for me because you spoke to me in the way I understood it, could digest it, and then apply it. So there's another component I didn't talk about before, but I'll talk about it now. We call those booster sessions. In those booster sessions, we provided support for them after they got out of the Malcolm X College. So they went to college virtually. They went through that program, and then we knew there was some gaps in knowledge because we had done the same thing. But we saw that there are going to be some times where they're not going to get this information and they're going to need some additional support. So we did what we call booster sessions. And booster sessions answered the questions that were left unanswered after the initial training. So if the training spoke to anything about any protocols or processes and they didn't understand it, they could come to the booster session to get that further drill down on that information until they got that aha moment. Do you think it happened for everybody at the same time? No. But we knew that was going to happen. So if those who didn't need to come to a communities of practice or to a booster session, they didn't have to be there. But if you needed it, you could come as often as you want. Because learning never stops. And that shift was ever changing. And that support was always needed. So even asking questions regarding the vaccine, regarding the myths or facts about it, we had doctors come every time and talk to them, answer every question under the sun. So what are some of the questions you guys had about the vaccine or even the pandemic? Give me some of the questions. What were some of the questions? Side effects. Absolutely. What are the side effects? Am I going to grow another arm? And they asked that. And the doctor said, absolutely not. They asked, what is the mRNA vaccine made of? We heard this. Why do we need that? It was that fat component that helps deliver the vaccine. Then they're like, oh, I get it. So it was always really a level set, even in the areas when they were like, this is what we were told, but I don't understand. So always providing that support to just help break it down so it's not a constant swirl of just words and names that they didn't understand, but they wanted them to regurgitate on the phone. So we had to make sure, again, that they were surrounded with support and had what was applicable for them to do their job, no matter what question they asked. What's another question you heard about the vaccine? Yes.
Oh, it's going to be a live virus.
A live virus, absolutely. What else did you hear? How did they produce it so fast? That was a big one. That was a good one. They're like, we knew the government did it. Why? Why? What happened was, can I tell you what they told us? The experts told us. They say it was always work going on about the vaccine and how to deal with it. But when the pandemic hit, everybody threw their money in the same bucket. Let's figure it out. So because of that funding was now there, they were able to complete all those studies that they were doing all along. And it was already available, but they just needed a little more support. Because you know when doing some things, a lot of stuff is siloed. Everybody wants to get to the top first. So people were doing things independently. But when the pandemic happened, we had to be a collective and united front. And so that's why they were able to get it out so quickly, because the research is already there. So again, in order to get people to buy into the process, we had to deal with it. But that wasn't a bad thing, because I was wondering the same thing too, you know? So it really was just an evolution. It was so amazing to see people go from, I don't have a clue, to. I got this. So they were able to deal with those needs as they evolved to match now the new charge as far as what they were designed to do for this role. Because they went from being contact tracers to they were on the phone, they were doing boots on the ground work, and they had to evolve into all of these things after not knowing any of it. But because we applied this approach, we were able to take care of those needs in real time and give them that support. So much so that some of them have gone on to work for the Department of Public Health to do this work full time. They were able to become advocates, to be able to change laws. And they would have never have done it if the messaging was so above them that they didn't get it. So breaking down those silos of knowledge, even though it makes sense to you, when you're dealing with a community that has been at a disservice the entire historical existence of them, there's fear, there's rejection, there's resistance. And in order to get the buy-in, you have to be able to present information in a way that's equitable, that is in a way that's digestible, and in a way that people get it. So some of the lessons learned that we knew were valid was that constant support was key in making sure that people got the knowledge. And we broke it down to bite-sized, pureed components if needed to make sure people got it. Because we knew that in order to shift that mindset, we had to address the sort of elephant in the room. Because they were already doing the work because they cared about community. But this process took a little getting used to. Layering on those skills, making sure that what they needed, they got. So if they needed to know how to turn on the computer, we provided sessions for Computer Basics 101, actually 000. This is a mouse. This is your camera. This is how you change the screen. All of those things. Some just needed other support, but we gave them what they needed to make it equitable. We also know that you have to give people voice. You have to give them voice. And when you give them voice through knowledge and training and support, they're able to take that same energy that you gave them and apply it to the work at hand. Because now they believe in it. You've told me, you've unraveled all this red tape for me, and now I get it. So now I'm able to stand on my own 2 feet and share the same information. With standing up this workforce, now about 800 people, there are some things we have to really consider. It was done in urgency because the pandemic was upon us, right? And we had to do something. So if there is an instance in any of your organizations where you're trying to incorporate this type of energy or this model into your workforce, you want to consider all the components of how much knowledge do they know? What is it that we're going to need to support them in? Am I going to have to deal with technology? All these things need to be a foresight before you even get involved. And you have to have somebody there to be able to relate, to understand the process, and even understand the hesitancy, because everybody doesn't get it. Because if you've never been exposed to it, it doesn't make sense to you. But if you've been sitting in the midst of it for the majority of your life, you are a great conduit of sharing knowledge and getting that buy-in or getting that trust in place so you can get the job done. I am very passionate about community health work, about it being an equitable role, about giving and meeting people where they are, because we all come from different areas and walks of life. It does not make anyone less or greater. But what it does, it just lets you know that there are people in this space that's right next to you that could be going through the same thing you're going through. But you need one thing. You need someone to care. We all need that. And caring is applying appropriate processes in dealing with someone. So if you are someone who needs a little extra, we should be able to give you that. And if you don't need that much, that's okay too. But one thing the pandemic has highlighted has been we all have a commonality. We love, we live, we thrive when there is a cultivating environment. And I know it's taken a deeper dive than what the content says, but I want to give a message. We all need one another. Whether we believe it or not, we all need one another. And if I were in a different setting, I would have us write the things about us that made us uniquely us, write it on the wall. And then everybody go around the room and check off the things that you agree with or are just like you. And then we'll find out they're more alike than we are different. So making a little adjustment to connect is not a big reach. And that is how we apply that health literacy component to what we do, because I want to give you what you need to be successful. And that's what it's all about. I am not a big talker. I love to get input and your feedback or even any questions. So right now, I'm available to you. Ask me what you will. Yes.
So this training is absolutely incredible, and I'm thinking about thank you. So I love this training, absolutely incredible. And I teach a very similar class to undergraduates on UW-Madison's campus about how to provide clinical empathy, and that also includes cultural humility and motivational interviewing techniques. And I spend a whole semester on this stuff. And so I'm wondering, how long was it from the idea and beginning to train the community health workers to your initial launch?
Let me tell you about that. There was no time to think about any of that, because it was like, there's a fire, call the fire department, put the fire out. Pandemic, get the people, get them working. We knew we had to give them the foundational stuff to get started to do the work. But that cultural humility, that motivational interviewing, that came in the midst of it, as they got acclimated to the role. Within 30, 60 days, we were able to get them trained in community health work, which has all those components in it. It's typically a 40-hour training. We didn't have that kind of time. We had to limit it. We had to give them some work to do on their own. Then we gave them forward-facing Zoom trainings that would hit on some of the self-study, but then incorporate new knowledge. So they had this wraparound. But if anything they got in training, they said, I need some more of that. We gave them some more of that and invited those to those trainings who needed it. So we were providing that equity and the efficacy. So, self-efficacy, you choose what you need, and then I'm going to give you what you need. And if you don't need as much, that's okay. Don't come to this one. Come to what that's applicable to you. All right. Thanks for the question. Yes, I got you.
My question is about your training.
Yes.
And curious, do you share? Is it available? Does it cost something
It does.
to share it with me or
Well-
all of us? I have things to share.
So there are some components into reports on our website, which I think I have the Sinai. It's SinaiChicago.org. SINAI Chicago, one word, .org. There are some reports and findings on there. There are some individual enrolled trainings, they're like, that's negotiable. I'm not going to give any pricing because our managers can deal with that. But there are some components of the trainings that do exist, and they're on our website that you can glean from. But if there's additional or a deeper dive that you need, that can be talked about, okay? Yes.
What would you do differently now that you've been through the process? And what would you, from here on, what are you going to be doing?
Okay. What I would have done differently, because it wasn't just us by ourselves. We had 4 other people in bed with us, so to speak. What I would have done differently is, as I chose those community members, which was a good thing, because the people that were chosen were from the same communities that was hardest hit by COVID, right? So what I would have done differently was to make sure that the tools they needed to get started, they had them. Some of them were working off of cellular phones. Some of them were working off of tablets. Some of them had nothing, and they were just trying to figure it out. I would do a level set of what they needed to begin with. I still would have given them that training initially to do the work, and I still would have added on that supportive training. And that's what it's a part of what we do on a regular basis. What I continue to do is provide people a space to speak about what they're going through honestly. Let's talk about it, because a lot of times people don't want to tell you what's really going on, but it doesn't solve anything. So you want to make the space a comfortable space to be able to speak about what is it that you're having challenges with, so you can be supported. Because at the end of the day, Helen, I want you to be successful. So that continued support will always exist. That's something that we continue to do and will continue to do. But in the beginning, level set, see where the needs are, see what the literacy levels are, and see what people, their knowledge base, what do you know? So you know how to apply those specific trainings. Okay.
So I live and work in Pittsburgh, and within the past couple of years, have been trying, getting into the community health worker space. And my biggest issue, unfortunately, has been recruitment. So
Okay.
I'm wondering if you could share some examples of how you were able to recruit the workers throughout all of this.
Okay, that's a good question as well. Recruitment. So if I were to come to your neighborhood, Mary Kay, I want you to be a part of my program. I want you to come work with me. How do you feel about that? I need more information. And sometimes looking like me and looking like you, it might not necessarily gel. There may be a little pushback. There's no disrespect to that. That's just how we operate as people. So when you're connecting with folks, use the people that live in the communities that you're trying to connect with. All right? So if you're trying to reach an elderly population, let's get one of those seniors in there and let's get them to talk to their peers about the good work that's going on over here. If you're going to do community health work, I'm going to give you a secret. This is one of our trade secrets. You ready? Go ahead and invite some people from the community to a little session. Get them all together, buy them a little lunch. Tell them this is what we're trying to do. It's an amazing job. You'll be able to connect with people that look like you and understand like you, and we'll pay you to do it. And then as we talk about it, I can see your passion. I can gauge to see if you're really interested in this, and I can offer you some work if you're interested. So recruitment has to start wherever the population is you're trying to reach. And if it's at the grocery store, if it's going to play bingo, if it's going to the salon, those spaces, it makes sense to meet people where they are and use people who look like the community that you're trying to reach in order to get that recruitment. Okay? I hope that helps. Okay. Anybody else? Oh, sure.
Has the community health worker has the topic expanded outside of COVID, and what kind of work are they doing right now?
Oh, absolutely. So the community health worker model is one that has, again, it's been the buzzword now, but has been in existence since the 60s officially, but longer before that with shamans and other medicine men. So now it's going beyond just medical, it's advocacy. People are doing a lot of policy making, and some of these inspirations came from doing the work with COVID. With COVID-19, people were inspired to say, okay, this area needs more support. This area needs my voice, and they have been inspired to do more than just COVID. Some of them want to go to specific medical disciplines like oncology or behavioral health. And you say, how can a community health worker do something like that? Because they become your partner in this process. They don't take over anybody's role. They become an extension of that medical professional or the professional that exists in that field. What you do with them, you tell them, I need you to reiterate to Emma. Tell Emma, this is what I want her to do. Because I've been telling her this in clinic, and she hasn't been getting it. I don't know if I'm doing a good job. So I go to Emma, and I say, Emma, I'm checking in on you. Tell me what you know about your condition. And Emma gets to tell me. Then I'm able to pick up where she got that mistake or that error. I can correct it for her in this moment. And then Emma gets it now, because I'm going to ask her again. Now that we had this conversation, Emma, show me how you do it, or tell me what you understand. And then I come back over here, and I say, she gets it now. This is where the problem was. This is what she didn't understand, and now we've gone over it. She's okay. If I were in a different training, I would show you a picture of a house that I went into of an asthmatic patient. This patient, if you look at the house, you understand why she's sick. But if she goes into the doctor's office, she's not going to tell the doctor's office there's a gaping hole in her ceiling that's raining water. They just close the door and that room is mold. They're not going to go to the doctor and tell the doctor that. But if you tell me, Kim, her medicine, she has her medicine, and she's not getting better, go see. And I go see. And I'm like, whoa. Doctor, I can't even talk about asthma. Her house is a wreck. And that's what I go back and tell the doctor. Not like that, but you know, appropriately, I saw something that's going on. And they're able to now, I'm saying, we have to deal with this before I can even deal with the medicine issue, because she's not going to get better. So it's different things that have to happen at different stages of understanding and levels of understanding with our patients or the population that we're working with. We make assumptions because we do it every day. But there's a disconnect. Do you know that when the patient leaves the room, 3 out of the 5 things you told them to do, they don't remember 3 of them? And these are important. So it's important as you're wrapping up, you say, I want you to do this, this, and this. And ask them, what did I want you to remember? This, and this. And you're like, okay, I can let you go. But again, community health workers sit in spaces that become an extension of the professional. Not to take over. Work in tandem. That's why they're a good part of multidisciplinary teams as well. Because not only are they able to give you insight about community behaviors, they're able to spend a little extra time in those spaces that you have already went to school, got this amazing degree. You don't have to do that. Let us do that. Yes, ma'am, Christine. Another good question. Who are community health workers being paid by? Most community health worker programs are grant funded. It's not too sustainable, right? Others can be utilized through other payers like managed care organizations. So if a clinic says, I need somebody to go out and see about a patient, there's some coding that can be done to pay for a community health worker, but it's really about the organization itself. So those are some things, some logistical things that I cannot give guidance on, but that's a barrier. The funding is not sustainable because most of it is grant funded, but we're working on that. We're working on that. Yeah. Yes.
So you touched on this a little bit, but as we all know, time is always of the essence with most, if not all, of the work that we do. So I'm trying to figure out with my work a lot of times, so I work for the state of Wisconsin in communications for our division of Medicaid. So a lot of communicating with people that receive Medicaid benefits from the state, which can be a complex topic.
Yes.
But there's always new policies and laws and a lot of information to get out.
Yes.
So a lot of times we miss out on asking the community health workers what training resources are helpful or how we did on the training resources that we gave them. And a lot of times from leadership, we just need to put out the next thing, get the next resource created, and not as much time getting feedback or talking about the resources that are needed. So how do you recommend advocating for bringing in more time talking to the people that need the resources? You touched a little bit when you spoke on how you had the urgency to get people on the phones right away, but you found a balance of giving them the bare bones training and then continued giving the training further. Can you talk a little bit about that?
I sure can, because that's important. That means they need an advocate. You have to be a voice in uncomfortable situations when it comes to this. And I know we hate to push against the grind, you want to buck against it, but it's okay. Because what the bottom line is that because you're not including them, you're doing repetitive work or not equitable work that you could be doing if you just ask. We get feedback all the time. There's never a training that we do not get feedback from. We ask them what went well, what do you need, what is broken, what's your feedback, because we don't have it all. And that's the standpoint we have to come from. You don't know it all, we don't. So I need you to tell me, did I do a good job? And if I didn't, what could I improve? And I need to help you. What do you need more of to support so I can support you in doing your role better? You have to be an advocate, and you have to be able to just talk about it and state your point. You're telling them this because the bottom line, we need this to make a good product or to support our patient base. Because if they don't know, how can they share the knowledge? You got to be an advocate with some big shoulders. Like, look. Yes.
I'm wondering what other organizations you had to get on board with you to make this project successful. We heard about barbershops yesterday. I'm wondering maybe churches or some others like that. Who are your partners?
Well, a lot of the community-based organizations were doing some social service work in the communities already. People that were re-entering in from prison, folks who were seniors, they were now retired, they were looking for supplemental work, all these things. But yes, in your communities that you're serving, you have rich resources in what already exists there. People hang out and gather at places like barbershops and salons, and even going to do laundry, they hang out in places like that. But you also want some higher level connectivity too. You want to be able to connect to the places that are the food pantries that are giving out the food. You want to be able to connect with some of these community clinics that are sitting there. You want that buy-in. And what we had the Department of Public Health that was the one who got this money. We know that we need to do this differently to reach the people that are most affected by this pandemic. And so then we're like, okay, 31 community-based organizations who are already doing good work. Let us fund you to get some more people on your team to do the work. So you want to filter out into those communities that you're trying to reach and see the places that are already doing good stuff. And then introduce them to the model, right? And then even support them in standing it up in their own organizations, because a lot of their funding gets cut out quickly because there's not sustainability. But there's anywhere people abide, it's an opportunity to make a connection and connect people to care. I would encourage it. Yes. Oh, there's a question
got one
back
back
here,
here,
then up here. Okay.
Thank you so much for this great session. I work for the Aging and Disability Resource Center for Barron, Ruskin, Washburn County in northern Wisconsin, and we have a grant for 2 community health workers to start soon. One of them's going to be working in the areas of Alzheimer's education, and another one in connecting people with services to, avoid hospital readmission, et cetera. So I do communications work, and I've been asked to develop some messaging or communication to let people know that this is legit, that they should accept this help, so to speak. And I realize that obviously trust and who the messenger is going to be a big piece of that. But any suggestions on what to say to people who've never heard of this concept before?
Yes, I have an idea. It is about spreading the message. So if I'm going to tell somebody there's a party coming up on the 4th, I'm going to say, you know what, it's a party. We're going to celebrate this. This is going to be the theme, and I want you to wear this. I'm getting you ready. So when the day comes, you can be ready for the party. Same thing with community health workers. When you are speaking about them, talk about them in a way that people understand their role and what they are going to be doing. Get the community health worker. Come on, Donna. This is Donna. She's going to be our new community health worker. What she's going to do, she's going to provide some more education about this condition and provide support for some social services. When you see her knocking on your door or calling on the phone, answer her call. We did that with the program too. We pushed that. We introduced what is contact tracing. They put messaging on television to say, when you see this number, pick it up. So it's about getting the message out before the implementation happens. And that's another best practice I would do. Get the message out before the implementation happens so people don't reject the service. Because if I never heard about it, you're trying to trick me. You're trying to swindle me. You're trying to scam me. Because I'm already nervous anyway about this. So the intro before the intro is a big difference. Huge. Blue.
Yep, the last question here.
Yeah, okay.
So now you've got this trained group of experienced mobilizers who know who to talk to in their community and how to
Yes.
spread a message. How can you change the theme of the party, or can you change the theme of the party and get them to talk about a new topic? We have the impending Medicaid unwinding coming up, and I know that's on some people's minds. How can we utilize those same trained workers to talk about a new topic to their groups?
I'm glad
Do
you
you
asked.
need new leadership to start spreading that message and support the same workers who are effective in their communities?
Okay, so the same workers have been dealing with COVID, right? So those same workers had to be shifted to vaccine. How would share the message of vaccine hesitancy? Those same workers are now implementing surveys to get data collection from what's been happening with them throughout the pandemic so they can get those results back. So we want to switch the topic. You can definitely do that, but you have to level set with the training. So what is it that you need them to know to effectively share the message to community so you get them ready? Get your team ready. Get the party planner. Get them ready. What's your budget? Let's get it together. And you get people prepared by getting them acclimated to what's going to happen. So if you want me to know as a community health worker about this, let's get a session together, because that's what we do. We tell them this is going to happen. They do this in Earn and Learn. There are opportunities for them to learn about every aspect of public health, from insurance to citizen science, from every area. But they have a training to get them ready before they implement the work and have that support. So if I have questions along the way, can I come back to you and ask you? They need that support. They absolutely need it. I see one, I think I gotta go. There was, it's about quit o'clock. So I really, again, appreciate you guys. But I need you to stay still for 1 second. I need to take a picture for work. They probably won't believe I was here, but I was here, I came here. So if you don't mind, just put on your best face. I'm gonna take this quick photo opportunity. Cheese, yay. Thank you guys, thank you so much for being here. I hope it was helpful.